It's my great honor and pleasure to introduce the second speaker tonight, which is Professor Piscaglia. He is working in Bologna, in the University of Bologna, and I'm not sure if we can see his presentation.
Hello, everybody. I know these are tough times, but we have to look ahead, to look into the future, and we really are eager to continue for those who are using or go back to our standard diagnostic systems. So today I will talk about the Lyrids classification system for HCC suspected lesions. So let's start from the HCC suspected lesions. So to go ahead, okay. So ultrasonography, ultrasonography is the surveillance tool recommended by all international guidelines to be performed in patients at risk for HCC. These mainly correspond to cirrhotic patients. I'm not going into details of a few additional categories, but most of them corresponding to patients with advanced chronic liver disease, regardless of the etiology. So with ultrasound, we detect hopefully tiny lesions, because the aim, the final goal, is to detect lesions when they are small and better curable. But ultrasonography is unable to make a differential diagnosis alone. For instance, these lesions which appear similar, where this is a biopsy-proven hepatocellular carcinoma, and this was a biopsy-proven regenerative nodule. These were two hypoechoic lesions, and these are two tiny hyperechoic lesions. This was resected, it was an HCC, and this was stable over several years and was addressed as a regenerative nodule. So even in the instance of hyperechoic lesions, then when seen out of a condition of a suspicion of a patient to be at risk for HCC, are classified as hemangioma. When we see the same lesions in patient at risk for HCC, we cannot establish a diagnosis of hemangioma as we do in healthy liver. And more in detail, if these lesions are detected concurrently with the detection of cirrhosis, half of them were actually hemangioma, where half were hepatocellular carcinoma. So even though some of them might still be hemangioma, we cannot establish a diagnosis by conventional grayscale ultrasound alone. We need to have the confirmation of this by contrast imaging. On the contrary, if no lesion were present in the past in a cirrhotic patient and during surveillance a hyperechoic lesion occurs, then in this case there was almost no possibility of having a hemangioma. There might be either hepatocellular carcinoma or regenerative nodules with or without dysplasia. So altogether, even when we see a lesion, that theoretically might appear as a hemangioma, never put in your report that this is a hemangioma. Always put that it is a hepatocellular lesion until differently demonstrated. This is very important. So we found the lesion. From a statistical and probability point of view, what we expect to see. To be very brief, these are different prospective studies run in Barcelona, in Spain, or in Italy, in Milan or Bologna. And to make a summary, from a likely point of view, if the lesion is very small, less than 2 centimeters, about 2/3 are already hepatocellular carcinoma. If we look at slightly bigger lesions, 2 to 3 centimeters, 85% are hepatocellular carcinoma. If the lesion has arisen in a background of cirrhosis and it is more than 3 centimeters, then the risk of hepatocellular carcinoma is more than 90%. So when we see a lesion, we should start immediately to think that this is an hepatocellular carcinoma until differently demonstrated. And if finally it is not an hepatocellular carcinoma, we know that the vast majority are regenerative nodules with or without dysplasia, and the minority, altogether about 3 to 4%, might be hemangioma, cholangiocellular carcinoma, primary lymphoma, or metastases from other organs or other extremely rare entities. All these bullet points 2 to 5 make altogether 2 to 4-5% of the cases of new lesions in cirrhosis. So we held that this is suspicious for HCC, and this is the starting point of the Lyrids approach. So what does Lyrids means? It means liver imaging reporting and data system. So it is a modality of reporting the appearance of lesions at risk for hepatocellular carcinoma. This is one of the latest release. The project started at the beginning only for the report of CT and MRI in 2013, but already at the end of 2016, as we will see, we had the CEUS Lyrids system. So the CEUS Lyrids system is different from any other category, any other classification system for HCC, because it grades the risk of a lesion to be an hepatocellular carcinoma. It starts from LR1 and it goes to LR5, where LR5 is definitively hepatocellular carcinoma. And from 1 to 5, there is a progression in the risk of being hepatocellular carcinoma. And then it importantly added an appearance, which is CEUS LRM, where M stands for malignant, which are lesions that look malignant, but are not specific for hepatocellular carcinoma. What is the goal of the Lyrids? It has the aim of standardizing terminology and criteria to interpret and report imaging examinations of the liver, because in many different countries there were different modalities to express, for instance, the appearance: hypervascular lesion, washing in lesion, hyper-enhancing lesion, bright lesion, hyperechoic lesions, and then we don't know in the end what are the imaging experts talking about. wash in followed by washout, hypoechoic appearance, whether it is only when it becomes less echoic than before or less echoic than the surrounding parenchyma. So there was a need for standardization. And this was supported by the American College and promoted by the American College of Radiology. And every year or every 2 years, it is updated as it is a dynamic document. And currently, we are working on the manual of the CEUS Lyrids 2020 edition that will come soon. So it started with CT or MRI. So it, as you can see here, we don't into any detail, but it shows images of how to interpret the pattern and how the pattern should be collected. It also showed the different patterns of the lesions, how they might appear. And this was back in 2013 for CT and MRI. So before the advent of the Lyrids, how did we use the imaging according to the guidelines to establish a diagnosis in the setting of lesions at risk for HCC? These are the European guidelines of the European Association for the Study of the Liver that are practically identical to the American guidelines at that time. Here we are in 2012, so before the Lyrids. And we had only two alternatives. If CT and MRI, so we don't see CEUS, were able to establish a diagnosis of HCC, then we had an HCC. If it was not typical, it was always mandatory to have biopsy. Obviously, this is a black and white picture, and not all lesions fall into the categories. For instance, we might have lesions which do not fulfill the criteria to be HCC, but cannot be biopsied. So we don't know where to put these lesions. And moreover, if a lesion biopsy might be false negative, and these lesions, we don't know whether they have a higher or lower risk of being hepatocellular carcinoma. For instance, a patient might have 3 different lesions, and often it is difficult to take a biopsy in all of them. So we might take a biopsy in the biggest, but then we don't know what the smaller are. So it is important to grade the risk of being an HCC and not only to have a black and white HCC or not HCC landscape. So this was the situation. And so as I mentioned, if the lesion is not an HCC imaging, cannot be biopsied, there was no standard modality to express the opinion of the imaging operator to the referring clinician about whether the probability of HCC is high or low. Because what happened in the past is that the report said this lesion does not achieve the criteria to be an HCC. So the expert knew that in this situation biopsy was mandatory, but I often saw in the past the general practitioner say, okay, this does not reach the criteria to be an HCC. Oh, okay, very happy. This is a benign lesion. And obviously this is a very wrong situation. It is different if you say this is not an HCC, but is a class at high or medium risk of being an HCC. So the clinician knows that there is a risk of HCC, even if the criteria for diagnosing hepatocellular carcinoma are not fully met. So to me, it was very clear that there was a need for some grading system of the risk of HCC. As I mentioned, it started with CT and MRI, slightly after that guidelines that endorsed only CT and MRI. But nowadays, Lyrids system is expanded to include also contrast-enhanced ultrasound. And this happened about 3 years ago, 3.5 years ago, at the end of 2016. And this helps also the ultrasonographers to apply consistent terminology, to reduce imaging interpretation variability and errors, to enhance the communication between ultrasound expert and referring clinicians. Sometimes they coincide, but sometimes they do not. And also the graduation facilitate quality assurance and research, and integration and correlation between imaging modalities. And in the end, it enhances the communication with the patient and the understanding by patients. Moreover, it was already mentioned that there was a problem because it was found that the typical criteria for contrast-enhanced ultrasound, which was hyperannouncement followed by washout, without any further detail of how this washout should be, were at risk of diagnosis for hepatocellular carcinoma, what instead was a cholangiocellular carcinoma. As I mentioned in my introduction, about 2% of new lesions in cirrhosis in the end are cholangiocellular carcinoma, and half of them do have the pattern of hyperannouncement followed by washout. So we knew that according to the criteria adopted before the EFSUMB guidelines, which for first identified a different pattern, and then by the Lyrids criteria, if we don't apply more specific criteria, about 1% of the lesions might be misdiagnosed for HCC while they are cholangiocellular carcinoma. And this is something that we wanted to avoid, because hepatocellular carcinoma is a unique tumor that can be diagnosed by imaging alone. So imaging must be almost totally predictive, totally specific for hepatocellular carcinoma, with no risk of misdiagnosis. So with this in mind, the CEUS Lyrids committee, to which I had the honor and pleasure to take part, and so to contribute heavily to the design of the CEUS Lyrids criteria, worked for about 2.5 years, from April 2014 to the end of 2016, until the algorithm was made public after endorsement by the American College of Radiology, and here is where you can find it. So differences between CEUS, Lyrids, and CT and MRI. CT and MRI speak about observations, because what they see is usually only represented by enhancement, but they don't see the lesion, especially CT. While with ultrasonography, we start from a lesion that we see. So we prefer to speak about a nodule and not an observation. Actually, with CEUS, very rarely we have false positive for a lesion with contrast enhancement, pseudo lesions. Then, when we see a lesion, we classify it according to the CEUS pattern. The lesion might invade the portal vessels of the hepatic veins, so we have a tumor in vein, or we grade, and we will see how from CEUS Lyrids 1, a lesion that is definitively 100% certain benign, Lyrids 2, when is probably, very highly probably benign, and in this pattern there should be less than 10% of cases which finally are HCC. So lesion might be classified as likely benign or likely malignant, but not surely hepatocellular carcinoma, so CEUS LRM. If they are probably hepatocellular, but not surely benign and not surely other malignancy, then they are classified as an intermediate risk of hepatocellular carcinoma, probably hepatocellular carcinoma, or definitively hepatocellular carcinoma, with the classes LR3, LR4, and LR5. And here you can see in the table the criteria to make the different diagnoses. So arterial phase hyperannouncement, not rim and not peripheral discontinuous globular, which are typical of metastasis of non-hepatocellular cancer and hemangioma respectively, followed by absence of washout, more than 10 millimeters are LR4, whereas if the washout is present, it is LR5 only if it is late. Late means that the onset of washout starts after 60 seconds from injection, and it should be mild at 2 minutes after injection. We don't grade the degree of washout, the severity of washout later, because then it is heavily depending on the equipment that they're using, on the amount of contrast that you have injected, and possibly of other hemodynamic conditions. So the degree of washout, whether mild or marked, has to be assessed at 2 minutes to classify a lesion as LR5. So to make some examples, CEUS Lyrids 1, totally benign. Usually these correspond to simple cyst or classic hemangioma or focal fatty sparring or deposition. Here we see an example in a patient with an HCC. He also has this anechoic lesion, which obviously looks liquid, and there is no enhancement at all, and this is confirmed to be a simple cyst. So we can state this is LR1. This is a peripheral globular enhancement with progressive filling from the periphery to the center of the lesion, and it remains hyper enhancing in the late phase. So this is a typical hemangioma in a fatty liver with moderate stiffness, moderate increase in stiffness, so potentially at risk for the hepatocellular carcinoma, but this is typically a hemangioma and can be classified as LR1. If you are not sure of any, or you have any doubt about hemangioma, please send the patient to have MRI, which is the gold standard for hemangioma. CEUS LR2, these are lesions most likely to be benign, but not completely sure. And these rarely occur in CEUS because we start from a nodule that can be seen with ultrasonography. So when we see a nodule, very rarely the risk of hepatocellular carcinoma is very small. So CEUS LR2 are rarely met, and these occur only when there is a very tiny lesion, less than 10 millimeter, or not a clear lesion, so some inhomogeneity, with ISO enhancement in all phases, or, a lesion that was previously LR3 in the admitted risk of HCC, but has been stable in size for more than 2 years. So this can be downgraded to LR2. And these usually correspond to cirrhotic regenerative nodules or low-grade dysplastic nodules. And in this case, we continue follow-up as usual. Some examples: tiny lesions, tiny lesion, 9 millimeter, ISO enhancing in the arterial phase, 27 seconds after injection, ISO enhancing also in the portal and late phase, LR2. This is probably a focal fatty sparing because it is not clearly lesion, ill-defined, and we see this in patients who maybe change weight, who are cirrhotic, stop drinking, there is inhomogeneity in the amount of fat. So we go with CEUS, ISO enhancing in all phases, no pattern of focal liver lesion. So these areas can be assigned the class LR2. Then LR3, more than 10 millimeter lesion, ISO enhancing in all phases. If it was less than 10, it is LR2. Or any size solid nodules with arterial phase hypoenhancement but without washout, or a lesion with arterial phase ISO or hypoenhancement, and when there is mild and late washout, it has to be small, less than 20 millimeters. In all these cases, the risk of HCC is intermediate. Or very tiny lesions with arterial phase hyperenhancement and no washout, because these lesions are very difficult to be diagnosed as they are very small. So these lesions are intermediate risk of HCC. Appropriate management is variable. We often perform biopsy in Bologna, especially if there are more than 20 millimeters ISO enhancing, more than 20 millimeters ISO enhancing in all phases, or they are more than 15 millimeters with washout, because they not rarely they are HCC. So the aim is to detect them as small as possible. Here to make some examples: tiny lesion, obviously and clearly hypoenhancing in the arterial phase, and then it tends to fill with bubbles in the portal phase, and it is ISO enhancing in the late phase. So this is a hyperechoic lesion. The enhancement is not globular peripheral, and the progressive refill does not come from the periphery to the center, but the entire lesion enhances progressively. And so this is not a hemangioma, and this is a LR3 lesion. This is a hyperechoic lesion that you can see here. It is between the hepatic vessels, ISO or slightly hypoenhancing in the arterial phase, ISO. So again, LR3. This does not exclude HCC, intermediate risk, about 45%. Then LR4. Here we are already probably in the field of HCC. So LR3, the probability, as I said, is about 45%. In LR4 is 85% of being an hepatocellular carcinoma. And we classify as LR4 lesions that are more than 20 millimeters without arterial phase hyperenhancement, that we know is very suggestive of hepatocellular carcinoma, but with mild and late washout. So the risk of HCC is very high if they are more than 2 centimeters. Otherwise, they are LR3. Also, the typical pattern of hepatocellular carcinoma, which is arterial phase hyperenhancement, which is this word APHE, with mild and late washout, that we know is distinct for hepatocellular carcinoma, is however classified as highly probable but not definitive when they are very small, only a few millimeters, to avoid some fistulas or some derangements might make a misdiagnosis. Or more than 10 millimeter lesion with arterial phase hyperenhancement but without washout. So all these conditions make lesions to be at high risk of being hepatocellular carcinoma. Usually these lesions are either biopsied or sometimes directly treated, depending on the situation that we have. If, for instance, the patient has another lesion, which is a hepatocellular carcinoma, and he has a second lesion, which is LR4, usually we treat both of them. So this needs a local multidisciplinary meeting. Some examples: 17 millimeter lesion, hyperenhancing in the arterial phase, but no washout at all in the later phases. This is a tiny lesion, 8 millimeter hyperechoic lesion, hyperenhancing the arterial phase, and mild washout at about 2 minutes. So late onset after 1 minute, because you see that at 1 minute and a half there is no washout, and mild. But since it is less than 1 centimeter, this is LR4. This is a hypoechoic lesion, no hyperenhancement, 21 millimeters, so more than 2 centimeters, but there is washout in the late phase. So this is again in a cirrhotic patient. This is again LR4. LR5 is the typical HCC. We can have this lesion as HCC, we can proceed to treatment. And it is more than 10 millimeter lesions with arterial phase hyperenhancement in whole or in part, but not rim and not peripheral discontinuous global enhancement, followed by mild and late washout. Typically, it is in whole, global hyperenhancement. And washout must begin after 60 seconds and needs to be mild at 2 minutes. You might ask, what is a mild and a washout? This is difficult to quantify. It might become possible with quantifying system, quantifying softwares. At present, it is potentially variable with different equipment, so it is left to the operator. But I can tell you that the most important criteria is the early versus late onset rather than mild versus severe. And these lesions are to be managed for HCC. So this is the typical definition that we remarked in this editorial. We strongly recommend to adopt this definition for LR5. Example, hyperenhancement in the arterial phase and washout. This is a large lesion, hyperenhancement, and washout, which starts only very late, and it is mild. But this makes it typical, and indeed it was resected, and it was a well-differentiated hepatocellular carcinoma. Okay, this is another typical example, hyperenhancement followed by late and mild washout. Tumor in vein, it is when we see echoic material, soft tissue, and with arterial phase hyperenhancement. I skip to the end. This is material inside the vein, and this enlarges the portal tract, and it has enhancement and washout. And this is malignant portal vein invasion, not thrombosis, but invasion. This is again one branch of portal vein invasion close to a treated HCC. At last, a nodule with some enhancement in the arterial phase, not completely devoid, with early, before 60 seconds, washout, or marked punched out appearance, black appearance at 2 minutes. Any of this pattern, either early washout or marked washout, or arterial phase rim enhancement followed by washout, regardless of the type, any of this pattern indicates a malignant lesion, but not surely an hepatocellular lesion. So some patterns, this is early washout, 38 seconds, and marked. And this is hyperenhancement, early washout at 30 seconds, and not very marked, but early. Actually, this was a poorly differentiated hepatocellular carcinoma. So usually when they have the LRM pattern, they are hepatocellular carcinoma poorly differentiated, or 50% of the cases, they are not hepatocellular carcinoma, they are cholangiocellular carcinoma or metastasis. So I skip for the sake of time. This is another LRM, which was a cholangiocarcinoma, early washout, with global hyperenhancement. So the global hyperenhancement is not typical only of hepatocellular carcinoma. The Lyrids system endorses also some ancillary features, but they are not very important for HCC. So I come to the end. When we see LR5, we have 98.5 lesions that are HCC. So very high positive predictive values. When they are LR4, it is 86. If they are not hepatocellular carcinoma, they are regenerative nodules. While, as you can see here, there is no more adopting this system of having a misdiagnosis with cholangiocellular carcinoma, because they all fall in LRM. And according to these studies, the new EFS guidelines endorsed the use of CEUS as you can see here, CEUS, evidence moderate, recommended weak, can be utilized for the diagnosis of hepatocellular carcinoma. As you can see here, you start with CT of MRI because these can be utilized for staging, but if they are contraindicated or they are inconclusive, then you are allowed to use contrast and ultrasound. These are the guidelines of 2 years ago, and these are very important for the practice of hepatologists worldwide. You can find it in internet, and so please use it to establish a definitive diagnosis of HCC, this classification system, avoiding the risk of misdiagnosis with cholangiocellular carcinoma. It is useful to convey easy and clear information about the risk of a lesion to be a hepatocellular carcinoma for the hepatologist, and it allows also to permit the detection of progression of a lesion over time. If it was LR2 and it becomes LR4, it obviously is progressing to hepatocellular carcinoma. Thank you very much for your attention.
Thank you very much, Fabio. Very nice presentation. I have 2 questions related to treatment from the audience. So, do you think that CEUS can be used instead of CT or MR for follow-up after therapy? And what is the preferred time for follow-up?
No, the follow-up is mainly on CT and MRI because they are panoramic. When you have a lesion that has been treated for it was hepatocellular carcinoma, you are at a high risk of having hepatocellular carcinoma also somewhere else and other new lesions. So if we use only CEUS, CEUS is good to establish whether the treated lesion is dead or alive, but this is not enough. We have to look also for other lesions somewhere else. And we know that the sensitivity of ultrasound is not very high. So this is why at least twice a year you need CT or MRI. In between, you can utilize CEUS to detect local recurrence, but CEUS alone is not enough for the follow-up of treated lesions.
Okay, thank you very much.